Good afternoon, everyone. My name is Dr. Brian Solomon. I'm one of the heart and lung surgeons at NCH Heart Institute in Naples, Florida. And today we're going to be talking about aortic valvular disease. It's a very common disease which affects a large portion of our population as we age. And it's an important topic that we talk about. And it's a true disease that we can actually fix and make people better. So that's why I want to get the word out and really get people understanding what is going on with aortic valvular disease and how we can make people healthier. If you'll bear with me, I am not that tech savvy, so I'm trying to figure out this Zoom meeting, and I'm going to try to switch over to a PowerPoint now. We're going to go through all of the information here. Okay, I hope everybody can see this. So the topic again is aortic valve disease, surgical therapy, and transcatheter aortic valve replacement. So what is aortic stenosis? Aortic stenosis is the buildup of calcium on the aortic valve, a valve which is the exit point of blood from the left ventricle of the heart. It causes it to narrow, to reduce blood flow, and reduce blood flow to the rest of the body. You see here an image, a cartoon that's created showing both a healthy aortic valve and a diseased aortic valve. It shows it in both the closed state and the open state. As we know, as the heart beats, the valve opens and allows blood to come out of the heart. It also closes to prevent the blood from flowing back into the heart. When we're born, the aortic valve usually has 3 leaflets and is generally very healthy and thin. Over time, just like we get plaque in our arteries, we can get plaque on our valves, and that plaque can cause the valve to tighten. And as a result, sometimes it can be stuck in the open position, but often it can be stuck in the closed position. When the leaflets become stiff, it reduces their ability to fully open or close. It creates a pressure gradient. When the leaflets don't fully open, the heart has to work significantly harder to push the blood through the valve. So what are the symptoms you may have if you have aortic stenosis? Well, people can complain of shortness of breath, fatigue, difficulty walking short distances, lightheadedness, dizziness, fainting, swollen ankles and feet, rapid fluttering heartbeat, or chest pain. Generally, they can have signs of what we call heart failure, and that sort of encompasses all of that. If it's taking you longer to undergo your physical activities that you used to enjoy or you're no longer able to do them, that may be a sign of heart failure, and it's something that we should investigate because it doesn't have to limit you. As I generally tell people, there's no such thing as normal aging causing limitations. If your aging is causing a limitation, there's a reason for it, and we need to look into it. The valve may be the reason. So the risk factors, what causes aortic stenosis? Well, the healthy aortic valve is shown, and so is the diseased aortic valve, and you see a blown up picture of what happens to this valve. The causes are generally calcium buildup. It can also be caused by a congenital birth defect, by rheumatic fever, or radiation therapy. Rheumatic fever is actually one of the more common reasons for this in the world, but in the United States and in most developed countries where we have access to antibiotics, it's a pretty rare finding. Risk factors for aortic stenosis include increasing age, high blood pressure, abnormal cholesterol levels, smoking, deformation of the aortic valve, and family history. And generally, a deformed aortic valve is referring to either an infection of the aortic valve causing damage to it, or can be referring to a birth defect to the aortic valve causing it to have 1 or 2 leaflets rather than 3. All of these are factors that can cause aortic stenosis to progress faster. And here we see some actual images of aortic valves. We see the trileaflet aortic valve on the upper left corner. We see a bicuspid or 2-leaflet aortic valve in the upper right corner. We see a unicuspid or a 1-leaflet aortic valve, which is completely immobile in the bottom left corner. And in the bottom right corner, we see a diseased aortic valve. You see the amount of calcium on it and the reason why it cannot move and cannot open and put so much stress on the heart. More common causes are generally aortic stenosis caused by age-related calcific stenosis. It's the same calcific deposits that happen with coronary disease and that happen with vascular disease. It's the deposits that cause damage to blood vessels and blood vessel components. There's just more of it, and it goes on the aortic valve, and as a result, the valve won't move. As I mentioned, there are also other factors, including rheumatic fever, very common in the non-developed world, not as common in the United States or developed countries that have access to treat rheumatic disease, and congenital abnormalities such as a bicuspid aortic valve, which occur in about 10 to 15% of individuals, but rarely cause issues. Though those that have bicuspid aortic valves are more likely to develop early onset aortic stenosis. The population at risk for aortic stenosis is increasing. As everyone understands, in Naples, we have an older community than the average. And as a result, we have a lot of people at risk for aortic stenosis and valvular heart disease. The population of the United States in general is significantly older than it used to be. There are about 2.5 million people in the United States over the age of 75 that suffer from this disease. Aortic stenosis is estimated to be prevalent in 12.4% of the population over 75 years old. What's even more concerning is as our medicine is getting better, the elderly population is going to more than double between now and the year 2050 to 80 million people, meaning there will be more people alive living longer and more time to develop this disease. One scary fact is that at least 40% of people who need a valve replacement do not get treatment. Aortic stenosis tends to be very undertreated in our population. And we've seen here we list 7 different studies between the years 1999 and 2010. And they show that this number ranges from 43% of people that had aortic stenosis that did not get surgical therapy to up to 74% in certain populations. It depends on the area, it depends on the population, it depends on the aggressiveness of the physician, and it depends on the approach. And we're going to see that this number is significantly decreasing over the last 20 years because of newer approaches, minimally invasive approaches, and transcatheter approaches to treat this disease without the significant amount of surgery that used to be required. This is one of the more important graphs for aortic stenosis in this entire talk. And this shows what I call the latent period of aortic stenosis. And what you can see here is as people progress with aortic stenosis, they go on throughout most of their life developing more and more disease to the aortic valve. But it reaches a critical point, and generally patients don't get any symptoms until it reaches that critical point. When they get onset of severe symptoms, if you can see the mouse here, it's pointing right to the onset of severe symptoms, they quickly have a drop in their survival. In fact, one of the most common signs of aortic stenosis, people present with no symptoms and have sudden death. We see the 3 most common symptoms that people present with are angina, meaning chest pain, syncope, meaning they get dizzy or pass out, or heart failure, meaning they could be short of breath and have other evidence of the heart failing. From the time of onset of symptoms, 50% of people will not survive a 2-year period. Only 20% of people with severe aortic stenosis and symptoms will be alive at 5 years unless this disease is treated. Surgical intervention should be performed as soon as any symptoms occur, even minor symptoms. Shortness of breath is the most critical finding. Patients who are short of breath or have heart failure have a 50% mortality at 1 year and nearly 100% mortality at 2 years. This disease has to be treated. What this graph doesn't show is a very important issue, which is this curve can be reversed. Once symptoms develop, the survival drops dramatically. But if we replace the aortic valve, the survival goes back to a straight line or a normal survival, and people can go on and live a normal, healthy life without issue. That's why it's so important that we treat this disease when it's found. This is just a graph that I like to show because it makes a really important point, because we hear a lot on TV and in the media about cancer, and we hear about how bad it is and how devastating it can be. and we look at the 5-year survival for different types of cancer, and we hear about bad ones like ovarian cancer and prostate cancer and breast cancer and lung cancer. And severe aortic stenosis has a 5-year survival that is significantly lower than any of these cancers. That's if it's untreated. The beauty is we can treat this and people can do well if it's treated and go back to a normal survival. So how do we diagnose this aortic stenosis? Well, the key to this is echocardiography. And I should take a step back and say the key to this is really meeting with your doctor and getting a really good physical exam. Nothing beats the benefit of having a doctor's expertise to listen to your heart, to determine from your symptoms what could be going on and determine the right type of testing. But once that's determined, we're going to send you for an echocardiogram. It's a relatively non-invasive image of the heart in 3D, sometimes 4D, where we can watch the actual valves move using ultrasound. There's no pain involved, and we're able to get a 3D picture of the heart and see exactly what's going on with all the different components, including the valve. Things we're looking for are the velocity in the valve area and the gradient. Functionally, I like to use the reference of a sprinkler or a hose when people are gardening. Water can flow out of a hose when you turn it on, and it can flow at a relatively low speed. But when you put your thumb and block most of it, all of a sudden, that water flows out really quickly and sprays everywhere. The pressure is higher and the speed is higher. And that's because of the blockage at the end of that. The aortic valve is the exact same thing. When it's blocked, blocking the outflow of fluid from the heart, we notice that the blood that's coming out and should be coming out at about 1 meter per second can jump up significantly in speed. When that speed hits 4 meters per second, we know the valve is severe. That equates to having a valve area of less than 1 square centimeter or a pressure gradient greater than 40 millimeters of mercury. It's a progressive disease, so we're going to look for changes. And if people are undergoing echo and showing that their valve is really progressing very quickly, that may be another reason for us to intervene earlier. Anybody whose valve decreases in size by more than half a square centimeter per year is a candidate for intervention or surgery. Another important thing we can see on the echocardiogram is aortic insufficiency or leaking of the valve. We'll talk a little bit more about that in a bit. As I mentioned, these are the echo guidelines, and this is not really meant for everybody to understand this, just to see that it's a complex system where we use several numbers, including gradients, jet velocities, valve areas, and indices in order to determine exactly when somebody is severe, when somebody is moderate, and when they're ready for treatment. And this is another interesting but very dense slide, which really just shows you the complexity and the recommendations for when people should be undergoing surgery to replace their aortic valve or transcatheter valve replacement. And what it shows is it's not a very straightforward answer. There's class 1 indication, meaning if your valve is severe and you've got symptoms, it should be replaced. But then it gets into a lot of other complex issues with low flow, low gradient, and different types of aortic valve stenosis, meaning you really need somebody who's an expert to go through these numbers and determine, are you ready for that valve replacement just yet? And this is just a further explanation of that graph showing how complicated this decision tree can be. Special considerations. I just mentioned something called low flow, low gradient aortic stenosis. And that's an important principle that really wasn't identified until the last 15 years. As I mentioned, aortic stenosis is generally classified by the flow velocity or the speed at which the blood is coming out of the heart through the valve. And that assumes that the heart is functioning normally. But if the aortic stenosis is progressive enough, causing damage to the heart, or if there's damage to the heart from other factors like coronary disease and the heart's unable to squeeze, it may not be able to create that squeeze in order to create that velocity or gradient. So we've got other tests we can do, including a dobutamine stress test, where we can try to force the heart to squeeze a little bit harder using some chemicals and try to evaluate the actual pressure gradients. We also have CT calcium scores and additional tests that we can determine whether or not, even in the setting of a poor squeeze, the heart actually has true aortic stenosis. And this is important because a lot of people that were being diagnosed with a bad aortic valve, but not quite bad enough to fix, were because their heart wasn't squeezing enough to show that it was bad enough to fix. And now that we know about this and have options to treat it, we can treat the valve, and sometimes the heart actually comes back and beats normally afterwards. So that's our goal. Another topic we're going to talk about is aortic insufficiency. Basically the opposite of what we've been talking about. Up until now, we've been talking about the aortic valve becoming too tight and preventing the blood from coming out. This is the opposite. It's a condition in which the aortic valve is too loose and unable to close appropriately. As you can understand, when the blood comes out, the valve opens and it allows the blood to come out, but not come back into the heart. If the valve fails to close properly, all of the blood that comes out can come backwards into the heart. That results in what we call retrograde flow, or the blood flowing back into the ventricle and stretching the ventricle out because there's too much volume in it. It can be caused by dysfunction of the leaflets, which is degenerative, or by dilation of the aorta, being an aneurysm. Either way, if that valve is stretched out and there's a hole in the center of it, the blood is going to leak backwards. Most common causes worldwide, again, are rheumatic disease. But as I mentioned, we don't have a ton of rheumatic disease in developed countries because of the access to antibiotics. In the United States, the two most common reasons for a leaking aortic valve are aortic aneurysms, which are stretching the tissue around the valve, causing the valve to leak, or a bicuspid aortic valve, or a congenital birth defect that about 10 to 20% of the population can be born with that can result in the valve leaking. So causes of aortic insufficiency, we'll just go through, as I said, it's broken down into degenerative and aneurysm. Under degenerative, there's rheumatic disease, there's endocarditis, or the aortic valve getting infected. There's trauma to the aortic valve. There is bicuspid aortic valve. There's rheumatoid arthritis, myxomatous degeneration, and acromegaly. Basically, what you need to get from this slide is there's a lot of different causes and a lot of things that can lead to this, and it can really affect anybody. As far as aneurysm, these are generally caused by hypertension in the vast majority of people, and smoking is a big factor leading to development of an aneurysm as well. Other factors that can lead to aortitis, which are far less commonly seen, are aortitis, syphilis, trauma, and collagen vascular disease. These are rare diseases like Marfan's disease, Ehlers-Danlos, or Louis-Dietz disease. Very uncommon, and they generally result in connective tissue disorders, which make the aorta much weaker and easier to dilate, and that results in leaking of the valve. This is the pathophysiology that as physicians we look at, and it just shows that when the valve is leaking, it causes more volume to go back into the heart, and that stretches the heart. And when the heart stretches, we look at the Starling curve, and as it stretches, it gets stronger until it reaches a certain point. When it stretches too much, all of a sudden the heart becomes weak, or what we call LV dysfunction. The stroke volume initially goes up and the blood pressure initially goes up, but all of this together can lead to ischemia or poor perfusion of the heart. And as a result, the dysfunction in the ischemia can lead to left ventricular failure, and that will end up leading to heart failure and decompensation of the patient. This basically says the same idea, but it shows that long-term, after you develop heart failure, with the stretching of the left atrium, the left ventricle, and the increase in pressure of both, the heart's initially going to increase the squeeze and try to maintain the cardiac output by increasing the heart rate and increasing the rate at which it squeezes. But eventually that's going to fail, and that's going to lead to shortness of breath, or what we call pulmonary edema, fluid in the heart, myocardial ischemia with low blood coronary perfusion pressure, and cardiogenic shock. We need to get to the aortic valve repair long before this happens in order to maintain a healthy heart. Signs and symptoms can be very similar to aortic stenosis. Generally, aortic insufficiency is very, very well tolerated by patients until it reaches a point where it's very severe. It's one of the more tolerated valvular lesions, so patients generally don't get treated until this leaking has been severe and caused the ventricle to dilate pretty badly. It often presents with left ventricular failure. What you're going to see with that is shortness of breath, fatigue, waking up in the middle of the night short of breath, and inability to catch your breath when you're laying flat. The signs include a collapsing pulse, a widened pulse pressure, meaning the top number and bottom number are really far apart, and a laterally displaced apical heartbeat. All things for your physician to look for when evaluating for aortic insufficiency. And there's a very specific mid-systolic and early diastolic murmur that your physician will be able to hear when listening to your chest to determine whether or not this is a aortic insufficiency, murmur. Again, the echo is the key to this entire process. If there's an abnormal finding on the examination, they'll send you for an echocardiogram and we can see. And what you see here on the left is we've got images of an aorta, and you see here this big color jet is the valve leaking backwards into the heart. When we see that, we know it's time to fix it because we can already see this ventricle is starting to dilate. And these are the waveforms that we measure through there, showing us exactly how much leaking and how much velocity is changing and pressure timing. This is just the same paradigm we talk about, how the physician's going to go through, look at the echo criteria, look at different measurements, including whether the leaflets are failed, the size of the vena contracta, the flow convergence, and the pressure half time. All things that are not really important for the patient to understand, but really important for the echocardiographer to understand. They're going to be able to measure it, and they're going to look at these quantitative numbers and grade the aortic insufficiency. And what we're going to do is we're going to classify this as mild, moderate, or severe. Mild and moderate, most of which can be treated medically, but once it becomes severe, we generally need to talk about treatment with surgery and replacement of the valve. Which brings me to my next point, treatment of aortic disease. This has changed a lot in the last 10 years. And I want to go through this because 10 years ago, 15 years ago, we really only had one option. And that was a big open surgery with about a 12-inch incision in the chest, putting the heart on bypass, arresting it, cutting the valve out, and putting a new one in. It was a long recovery. It works very well, but it was really our only option. Over the last 20 years, I should say, we've developed minimally invasive, and in the last 10 years, we've developed transcatheter approaches. And it's really opened up a new world for who we can treat and how we can treat aortic valve disease, and how much time people will spend in the hospital and how long they will spend recovering. So what I want to talk about is what are the options for treatment? What are the different approaches? When to opt for surgery versus a transcatheter valve, and what to expect with each option. The first is the surgical aortic valve replacement. This is what we talked about initially. This is the original way with the 10 to 12-inch incision in the chest. You see a picture of that here. We open the chest up, and it is the gold standard of aortic valve replacement. It has been around for about 40 years, and it works very well. We can replace the valve with a tissue valve made out of either a pig valve or a cow valve, which is actually tissue made from the pericardial sac of a cow and sized to fit a human heart. These can be sewn into the valve space after cutting the valve leaflets out, and it can work like a human valve for a prolonged period of time. We can also replace them with metal valves. We call them metal valves. In reality, they're actually made of a material like Kevlar, which is almost a hard plastic and allows it to move without any real resistance against the valve. Tissue valves have a life expectancy of about 15 to 20 years in the best setting, and people do very well with them. The nice benefit is when a tissue valve goes in, patients do not need to take any blood thinners. Mechanical valves theoretically have an unlimited lifespan. For a very young patient, it's a great option. The problem is with these valves, you need to take a blood thinner. The nice thing about the surgical aortic valve replacement is we have about 50 years of surgical experience and literature and understanding of how this works. We know what to predict and we know how to make it work well. We have a couple of new surgical valve options that I wanted to talk about very briefly, all of which are available at NCH and all of which we're using on a routine basis on almost all of our patients for surgical valves. The first is the Edwards Resilia technology, and that is a new type of tissue valve, which is now in a dry storage system. It does not need to be stored in water or any chemical, and it basically has a much longer storage life on the shelf. Now, why we care about it more importantly is because it has a new glycosylation procedure performed to it, which allows it to be dry stored, but also prevents it from being calcified when placed in the body. The result is we get a valve that lasts significantly longer in the body. And the new predictions by Edwards is that these valves may last as long as 20 to 25 years. Patients do very well with them. Their gradients postoperatively are wonderful, and patients really tolerate it very well. The other nice factor that we can talk about is it's designed with a fracturable internal ring. And that internal ring allows us to put a transcatheter valve inside it if the valve were to go bad in the future. and to expand the valve into a larger size. So if a 23 millimeter valve is put into a patient, we may be able to put a transcatheter 26 millimeter valve in the future and give the patient the best possible outcome rather than downsizing. The next thing is the mechanical valve. These are generally used on people with either very, very small aortas that are born with small aortas or people that are very young. The reason they're designed for very young people is because they've got an unlimited lifespan. The patient will not need a reoperation or need a second valve in the future. The downside is they will need anticoagulation or a blood thinner for the rest of their life. The new ones are made out of a pure carbon coating. They have a 90-degree leaflet opening. As you see, the valve opens straight up and down, allowing the maximum amount of blood to flow out of it with each beat. The hinge design is improved. And because of all of this, the new studies allow patients to have a much lower INR, meaning the amount of blood thinner they have to take after this operation is very low. It used to be 2 to 2.5, and now the patients are able to maintain at 1.5, which is a huge factor for us, given that the anticoagulation is the key reason people don't want to get this valve. The next option I'd like to talk about is minimally invasive aortic valve replacement. This is a very similar operation to the traditional sternotomy. The only difference is it's done through a 2.5, 3-inch incision in the chest rather than a 10 to 12-inch incision. We don't break the entire bone in the chest. We break only the top piece of it, and we basically expose only the amount that we need to in order to get the valve in. It's limited because fewer people know how to do this operation. At NCH, the majority of our procedures are done this way, as long as it's an isolated aortic valve replacement, and the patient doesn't need any other procedures done. We can do them almost all this way and have the same results, if not better results. As I said, it's the same operation as the surgical valve. So once you're in there, you're still going on bypass. We're still able to cut out the old valve. We're still able to put in the same types of valves available for open surgery. The results are you get less pain, you get a shorter length of stay, and generally patients are going home after 3 to 4 days in the hospital. We do quite a lot of these, and people are really happy with the results. The third option is the transcatheter aortic valve. This is the valve that we place through the groin. Most commonly performed by femoral access, meaning through the groin. It's a 14 French catheter. It goes in through the groin in a cath lab or a hybrid operating room. Does not require the patient to be on bypass, does not require an incision in the chest, and really results in a shorter hospital stay and less pain. Patients generally wake up from this procedure having no pain and generally are home the next day or the day after. It can be done through multiple approaches. This is going to be determined by the patient's vessel size, calcification, prior surgeries, and the safety. We can do it generally through the transfemoral or transiliac, meaning we stick in the groin, but we can also go through the bottom of the heart. We can go through the aorta. We can go through the arm, and we can go through the carotid artery if we have to. We've done each of these approaches at NCH. Each one has gone very well, and patients tolerate them very well. And even with the alternate approaches, patients are still going home in 1 to 2 days. It's really just a question of how to get to the heart with the catheters and make sure we can push this valve through the vessels to get there. This is an image of us doing a transcatheter valve. You see the team working together, surrounding the patient. And in this case, this is an alternate access, us going through the axillary artery in the arm, I believe. Oh no, I take that back. This is a carotid artery approach that we're doing, where we are going through the neck to go directly down to the heart. And we're going to place the valve with only about a 2-inch incision in the neck. The reason I'm pushing this so much is, as I mentioned before, aortic valve replacement greatly increases survival with severe aortic stenosis. You can see from this graph that somebody who goes untreated with aortic stenosis has a 50% chance of being dead within 2 years and about an 80 to 90% chance of being dead within 5 years. But if we fix the valve, they go up to a normal lifespan. And that's what we're aiming for. We really want to get people back to a normal lifespan and not to have to worry about the aortic disease. When we do a transcatheter procedure, we're going, it's going to be a structural heart team approach. That means that the surgeons, the interventional cardiologists, the anesthesiologists, The imaging cardiologists all get together to perform the procedure with the help of a cardiac surgical team, an interventional cardiology team, and a cardiac perfusion team. There's about 12 to 15 people in the room. It takes a lot of expertise, but because of that, we're able to give really great results with minimal exposure and minimal damage to, or minimal pain or exposure to the patient. The workup for this valve includes referral to a structural heart team. The patient is then seen by a team, generally of 1 or 2 surgeons and an interventional cardiologist. They're going to get a CAT scan of the chest, abdomen, pelvis, and lower extremities. We're going to use that CAT scan to reconstruct the arteries and make a 3D map so we can determine exactly how we can get the valve through the vessels and get it to the heart. We're going to get ultrasounds of the neck and of the veins. We're going to get echocardiograms. We're going to get blood work. We're going to do a 6-minute walk test, and we're going to do some questionnaires to determine exactly how frail the patient is and whether they're an appropriate candidate for this. And we're going to put all of that information together to determine whether the patient is a better candidate for a transcatheter valve or a surgical valve. The process for the transcatheter valve is actually pretty straightforward. People are admitted the day of the procedure. I have here that we go to the cath lab and it takes 1 to 2 hours. Honestly, we've now gotten so smooth that it takes about 45 minutes to put the valve in. Majority of patients have the breathing tube come out in the cath lab, and now we're actually starting to do these procedures without even putting people to sleep. They do it under some sedation and local anesthesia, and people never even need a breathing tube. People are admitted to our recovery unit, usually spend a few hours there. Sometimes they spend the night there, and then they'll go up to a regular room the next day. They may go home the next day. They may go home the day after, but the vast majority of our patients are home within about 36 hours. There are 2 valves that we use. The first is the Edwards Sapien valve, and that is the majority of our valves at NCH. It's a valve we're very comfortable with. This is slightly old data. It's a stainless steel frame. It's deployed by inflating a balloon inside the aorta to break the current valve and expand this one. It has a little bit more leaking around it, but less need for a pacemaker than the other valve. The Medtronic valve is a self-expanding valve, meaning that we don't need to blow up a balloon or break anything. It's scrunched down into the catheter, and as we open the catheter, the valve itself comes out and expands on its own. Slightly higher risk for a pacemaker, but less leak in the valve. And I will say that honestly, we've done both. The valves have gotten, I say this is old data because these came from the company with the images, and this is the 3rd generation. We're on the 4th generation now, and these valves rarely have any leak associated with them. They rarely have any pacemaker rate associated with them. And patients generally do very, very well with both of the valves. As I mentioned, the key to this is imaging. The key to this is preparation. I always tell my patients 90% of this procedure is done before they're ever in the room. It's all about reconstruction of the data and determining where to put the valve and how to get it in there and what size valve is appropriate. So we do 3D CAT scans, we measure every aspect of the valve, we do echoes, we do vascular studies, and we do a cardiac cath. You're seeing the images of all of those here. And we're going to take that data and put all of those pieces together to determine how to put the valve in, what route to take, and where to put it. What you're going to see here is a quick video that the Edwards company who makes the valve provided to us. And it really just shows the Sapien 3 valve being inserted through the groin, up through the aorta, and into the heart. And what you're seeing here, we have catheters in the groin. We're coming up through the aorta, and we're going to come around the aortic arch. You see the diseased valve there that's barely moving, and this is just a balloon here. We have a wire crossing into the heart. We stop the heart with a pacer, and we balloon it open. And that's simply going to help expand the valve and give us enough room and mobility to get the new valve inside there. The balloon's taken out, and over the same wire, we're going to come up with the new valve. Now, the valve cannot be placed already pre-made because it would be too big to go through the vessels. So we actually have to do this construction process inside the aorta where we pull the balloon into the valve and create the deployable valve in the aorta. So here we're measuring exactly how we place the balloon, and we're creating the system. And once it's created, we're going to come up and steer the valve over the aortic arch very carefully. making sure not to hit anything and not to scrape on the aorta and cause any damage. Once it's ready, we're going to bend that around the aorta and come into the valve, and we're going to use fluoroscopy, or a very high concentration X-ray, to make sure we're in the right position. We're going to unsheath the valve, and we're going to pace the heart again in about a second once the valve is positioned appropriately. And once the valve is positioned appropriately, as you're seeing here, the heart's about to start pacing. And we're going to expand the valve, put the valve in the right position, take down the balloon, and all of a sudden the patient has a beating heart with a new heart valve in it. All this with a needle stick in each groin. Patient outcomes continue to improve, and what we've seen is over the years, we're down to about 1% mortality from this procedure. That's in line with surgery, and really just showing excellent results. So as far as outcomes, this all started in about 2012 with what we call the partner trial. And that was evaluating patients that were too high risk for surgery to determine whether they would do better with medical management versus transcatheter valve. They were the inoperable patients. We placed these valves in them, and I'm going to go through this quickly because this really is the point that's geared towards the other doctors that I present to with the same talk. But really, the endpoints, we looked at patients that would die from this, all-cause mortality, and then we looked at some secondary points like cardiovascular death, heart functional class, 6-minute walk test, and valve performance. What it showed is equivocal results, meaning that over the first 3 years after this procedure, these very high-risk patients, whether they had a surgical valve or whether they had a transcatheter valve, did just about the same statistically. What this told us was that in high-risk patients, or patients that we deemed too high risk to operate on, the transcatheter valve was a very good option to treat them. Moving on to intermediate risk, as we do, we started with the high-risk people who would not do well with surgery to begin with. Then we started moving into people that were slightly lower risk. And to go through quickly, I can just say that we went through all of this similar study, similar breakdown, and we showed that patients did very well with intermediate risk as well. It was equivocal outcomes. Takeaway point, we then repeated this with the Partner 3 trial, which was the low-risk study. Similar trial, similar ideas, low-risk patients. It basically opened it up to all comers. And in this case, it actually showed that the transcatheter valve was superior to the surgical valve by a small margin at preventing death. The pitfalls is that patients generally were higher likelihood to need a pacemaker, higher likelihood of leaflet thrombosis, and higher likelihood to have a leak around the valve. Now, the most important pitfall of this study, which was released about 1.5 years ago, is that the data really only looked at 1 to 2 years. Low-risk patients, I think we need to be very open-minded about, because generally when an 85-year-old comes in with this disease, we know we have a valve that's going to last 5, 6, 7 years. That's probably a perfect option for them. But when the 65 or 70-year-old comes in and potentially has 25 years left to live, we need to go with a valve that we think is going to give them the best possible outcome. So I think the takeaway points is that TAVR is an excellent alternative to surgical aortic valve in the correct patient. It's indicated for high-risk patients, it's indicated for moderate-risk patients, and it's newly indicated for low-risk patients, as long as the right patient is selected. As I've mentioned, the biggest issue is we lack long-term data, especially longevity and durability of this valve. So people come by and the most common question is if I get the transcatheter valve, how long is this valve going to last me? The answer is I don't know. Nobody really has a good answer to give that, because unfortunately in low-risk patients, these valves have only been around for about 3 to 5 years. We don't have long-term data to give, especially compared to the surgical valves that have been around for 40 or 50 years. What it comes down to is I'm telling my patients, you can expect 5 to 8 years. It may go longer, it may not. We just don't know with these valves. In younger patients, they should truly consider a surgical valve if they are really worried about longevity and transcatheter valve is going to be an issue for them. We just don't know that answer. So I think it's worth keeping both options in mind and determining what's the right option for you. We can do it minimally invasively, or we can do it transcatheter, get similar results. As I said, the aortic valve disease can be treated safely in most patients with return to normal life expectancy. Surgery and transcatheter approaches provide similar outcomes, but long-term durability for the transcatheter valve is still unknown. Determining surgery versus transcatheter approach is based on a complex decision tree and should be determined in conjunction with a structural heart team, meaning that after your doctor refers you to the cardiologist, all of the cardiology team should meet to discuss what the right option is for that given patient. And certain factors may steer the physician away from a transcatheter valve. That includes aortic insufficiency, young age, long life expectancy, bicuspid aortic valve disease, other cardiac disease requiring surgical treatment, and poor vascular access. If there are any questions, you can feel free to contact me. Here's my number. I'm at the NCH Heart Institute. I'm happy to meet with anybody who has questions and to discuss this further and get them a referral to the exact physician they need to be with. And I don't see any questions listed here. If there are any questions, please let me know. Otherwise, have a wonderful day.